I've mentioned this briefly in another part regarding the cervical spine, but there are nerves that are secondarily injured or compressed or irritated as part of a more global neck problem. These are important to mention because, frankly, over the years, they were things that I sometimes missed. And these nerves, firing abnormally, will learn over time to automatically fire abnormally because that's a process that nerves go through in our bodies. It's why we can walk without thinking. Nerves tend to go through a process that's called automaticity. And even if we stabilize the cervical spine exactly the way it needs to be stabilized, sometimes these nerves will keep firing abnormal because of this automaticity problem, the most common of which is the greater occipital nerve. It roughly has a distribution that goes across here that can be burning, searing, numb, tingle, any type of nerve sort of sensation can happen with that nerve being compressed or irritated. There tends to be 3 places where that nerve can be compressed or irritated, but having the skill set through ultrasound and fluoroscopy to be able to identify where that compression occurs and use a procedure called hydrodissection, where we're using a needle very near to the nerve, right next to it, to push adhesions and compressing tissue away from that nerve, is a very critical skill set. My mind goes back to a patient who had 30 years of neck pain, first from an injury on a trampoline and then several car accidents. She had headaches and neck pain for 30 years. Was still a very functional individual, but was seeing 4 or 5 different kinds of practitioners and using lots of different kinds of medication for all of that time. Some of the procedures that I've developed are because of that patient. Being very careful to address those peripheral nerves as part of a neck problem is very important. This is something that's understood in the medical literature and known, but we don't want to only treat that nerve. We want to treat the underlying reason why that nerve is irritated, and then the nerve itself. With that particular patient, we had a deal that whenever she started to get an occipital nerve, greater occipital nerve headache, she would call me, she would come in, I would block the nerve, basically shut it down, stop it, tell it to stop going through this automatic cycle, and it took several times of doing that before the nerve reset itself and quit doing it. This was after great deals of procedures were done to create stability and healing of the deeper structures, which just led to only this nerve being the irritation. This is what I call, this patient was my teacher, essentially. She was motivated enough to allow me to try new ways of healing her, and we developed a new set of procedures for her. But those nerve structures are very important and need to be addressed as part of a whole when they're present.